Good morning. My name is Ann Brazo. I'm the founder and CEO of MPN Advocacy and Education International. Today is June 8th, and we are going to, we decided to have an open forum today because our conversations with the specialists over the last year have been so successful and very well attended by you, the patient, caregiver, and other healthcare professionals. Today we have two specialists from Memorial Sloan Kettering in New York City. We have Dr. Roni Tamari and Dr. Raajit Rampal. Roni is with us for the first time. We're very happy to meet her and are anxious to hear from her. We have numerous questions from all of you that we will desperately try to get through all of them today. We also would like to thank our industry partners. There are numerous partners these days, and as you can see, the list goes on and on. And we would just like to thank them for their support to make these programs possible. So moving right along, I would like to introduce separately Dr. Raajit Rampal. Dr. Rampal has been with us at so many of our events in person and has participated in these online programs as well. Many of you know him, and he's going to give a brief update of what's going on in his lab and in his world at this moment. Dr. Rampal.
Hi, Ann. It's always great to be here and have a chance to talk to our patient community about what's going on. I think the things I'll briefly touch on are that I think this is a really exciting time in MPNs. There are a number of drugs in development for MPNs, and there's three drugs being tested for upfront treatment of myelofibrosis in phase 3 trials. And that's important because that has the potential to change the standard of care. And I think it is a reasonable expectation that in the next several short years, we will change how we manage patients with myelofibrosis. And to some extent, the same may be true in polycythemia vera, where our paradigm has always been we only give patients medication if they're over age 60 or if they're high risk. But there's now data from last year that seems to suggest that maybe earlier treatment may be better. And I think that's one of the central themes that's really emerging to me is earlier treatment something we need to be thinking about for patients in general? There's been a lot of effort in this vein from the MPN Research Foundation and a lot of investigators as well, asking the question, why do we wait for the disease to get so bad? Why don't we think about intervening earlier, and can we potentially leverage what we know about the genetics and the biology to say, well, certain patients are high risk and they should be treated earlier, and others we can wait and see how things go. So I think that's another kind of major theme that is, in my mind, emerging about how we treat patients in general. I think aside from that, there's a couple of new studies coming out from our group here. We've just been doing some modeling and testing of new drugs in the lab in our MPN mice. And we've just published a paper in the last month where we looked at combining two new classes of drugs with JAK inhibitors and showed that, at least in the mice, it had a pretty profound effect. It caused the mice to actually survive longer, which we don't usually see. And so the interesting thing is that the drugs in question are now individually going to move forward in the clinic. One of them is what's called a PIM kinase inhibitor, and that's being tested by a company that's planning to launch a study in this area. And the other is a class of drugs called CDK4/6 inhibitors. And so that is a study that we're launching in collaboration with a pharmaceutical partner, and that trial we hope will open later this year. So that's all, we've kind of validated these ideas in the lab, and now they're moving into the real world, which is always, I think, exciting.
Fantastic. I mean, we're just overwhelmed here with all the literature and all the things that are happening, and you're spot on. So Dr. Tamari, again, thank you so much for joining us today for the first time. And we look forward to working with you in the future as well. Please share with us what you're working on and what you're seeing these days in the MPN world.
Sure. First, thank you very much for the invitation. A big pleasure and very excited to be here today. So my name is Roni Tamari and I'm an attending of the Adult Bone Marrow Transplant Service. And I see many patients with myelofibrosis that actually are referred to me from Raajit. So we work closely together. And I think that, as Dr. Rampal said, with the many new drugs that are becoming available, mostly on clinical trial for patients with myelofibrosis, things are really changing also for us on the transplant side, because we really see patients referred to us in much earlier stages than what we used to see them before. And we need to think very differently. And I think that many questions that come to us are actually when to look into transplanting a patient with myelofibrosis. We used to see patients actually much sicker referred to us, heavily transfused, and that affected the transplant outcomes. So we need to shift from what we are used to know about outcomes for transplant in myelofibrosis, where we see a lot of patients coming with advanced stages, very comorbid, meaning coming to us with other diseases which affect transplant outcomes, to patients at earlier stages and patients that actually have been responding to the various treatments. And it becomes a very challenging question where we know that still with all the drug, transplant is the only curative treatment. However, transplant does remain with significant effects on quality of life. And I think that to me, when I see a patient, that's one of the biggest challenges is when to recommend a transplant. So for that, and actually with the support of the MPN, we are looking into collaborate with many other transplant centers to increase the number of patients that we can study from, and then come and try to answer these questions on when to transplant patients with myelofibrosis, and also how to improve their outcomes, which obviously is our goal when we're transplanting patients.
Yes, yes, thank you. And to that, one of the questions is, will a PV patient or ET patient that's really having some issues ever be able to be transplanted? Because I know there's a lot of controversy about that in the MPN professional, in the physician researcher world, but we get a lot of questions like that from patients with polycythemia vera and also those that are doing fairly well, but want to make sure that they don't convert. And, what are your thoughts on that?
So I think at the end, it's a very individual question, and we need to ask ourselves, what are the symptoms we're trying to alleviate? And what are the potential outcomes of the transplant? And I think that, we tend to look at transplant as one fits all, but there are many, many changes actually in the transplant, the way we transplant patients, especially in the past, I would say decade, with reduced intensity conditioning, and also drugs for prevention and treatment for graft versus host disease. Mm-hmm. One of the new drugs that has been approved in the past couple of years is actually Jakafi for the treatment of graft versus host disease. So that's a very interesting aspect, particularly for patients with MPN. So I don't think this is a question that we can just answer as a yes or no. I think we should definitely evaluate these patients and assess why do we think they need a transplant, what are we trying to achieve, and what are the chances to have good outcomes.
Okay, thank you. So I'm going to move into these questions because there are so many, and what I might do is not ask both of you, but sometimes ask for both of your opinions. And if you think you want to add something to that, the question, please, or the answer, please do. So this is a question that Raajit and both of you probably hear often. What are the signs of progression? But can you be specific? What does it look like, and what have you seen in your practice? And that gives you the idea that perhaps another bone marrow biopsy. I mean, tell us exactly what you look for, Raajit.
Patients ask this question, and it's a very difficult question. And what I'll tell you is that, when we're designing clinical trials from the academic side or even from the pharma side, this question comes up all the time, because if you're going to design a trial for patients who are, for example, on Jakafi and progressing, the first question is, what do you mean by progressing? And I can tell you from having been in the room for lots of these conversations, there is some degree of consensus and there's a lot of disagreement. So I don't think that there's a universal definition that everybody agrees on right now. I think taking it out of the academic realm, let's talk about what are the obvious things, right? Let's focus first hematologically, right? If we're looking at somebody's blood counts, what are the things that tell me somebody's progressing? Well, a couple of things. If somebody had mild anemia and now they need transfusions of red cells, absolutely there's been a progression event. We also have to exclude that there's something else causing that, like iron deficiency or bleeding or some more simple things, but that often is a sign of progression. If somebody's platelets have been okay and now they're not, now their platelets are dipping into the below normal range, to me that's usually a sign of hematologic progression. If there is a consistent increase in blast counts, so the blast cells are the immature cells that we almost always see in patients with myelofibrosis, if that starts to increase steadily, that to me is hematologic evidence of progression. What about other signs and symptoms? So, on examination, we always examine a patient's spleen and liver size. And if that spleen or liver size is increasing, that is a sign of progression. But that's more of a gray area, because if somebody's spleen is increasing by, 1 or 2 or 3 fingers from one exam to another exam in 6 months, has it increased? Sure. Is it meaningful? That's where things get a little bit more ambiguous. But if the patient is now saying to us, well, it hurts or I can't eat anymore, and we see that there's an increase in the size, then it's meaningful. So I think, exam findings have to be put into context. And then there's the symptom component. So what's symptomatic progression? Well, that to me is patient defined, right? If somebody has been feeling well, now they're not, for whatever reason, if it's fatigue, if it's starting to have the night sweats, if it's starting to feel full or having, the abdominal discomfort or bone pain, and if those things weren't present before, that to me is symptomatic progression. So I think there's a lot of ways to define it, but there isn't one set definition.
Randy, do you have anything to add to that?
Yeah, I agree with everything Raajit said. I think additionally, what came into the clinical practice in the past couple of years is the mutation analysis and with next gene sequencing. And because we have this ongoing debate of when to transplant a patient, we always want to take them when they're in best clinical shape, but we don't want to do it too early. So for patients who are being referred to me at early stages, I do recommend periodic bone marrows, maybe in the absence of no changes in blood counts. I would probably do it not too often, maybe once a year, to see if there's any evidence of maybe new mutations or clonal evolution that suggests that something is going before we actually see clinical changes. However, I absolutely agree with Raajit that it needs to take into context. We don't want to act on things too early or too premature. But I think that this will come more and more into play. But at the same time, we need to understand more what it means.
Mm-hmm. So I'm going to jump around here. Do you recommend doing Procrit injectables in conjunction with blood transfusions, Raajit?
Well, it depends. I think that, if somebody is to the point where they need a blood transfusion, is Procrit a reasonable intervention? The answer is yes, potentially. It depends on a couple of things, though. 2 things in general. Number one, we check a patient's erythropoietin level, which is the endogenous amount of erythropoietin that their kidneys are making. If it's too high, if it's over, let's say 250 or really 500, that it is very, very, very unlikely the patient is going to respond to those injections. So if it's over 500, it's not even probably worth trying. But if it's below 100, it may work, and it may reduce the need for transfusions, maybe even eliminate it. But of course, nothing is without side effects. And so this class of drugs can be associated with a risk of heart attack and stroke, of hypertension, and in patients who have more than one malignancy. So we certainly see here patients who have an MPN plus a solid cancer, like a breast cancer, colon cancer, et cetera. That's also a potential contraindication because it does increase the risk of death in somebody who has a solid tumor. So the answer is yes, in certain circumstances, is absolutely reasonable.
If someone is on hydroxyurea, how long can their hemoglobin and hematocrits safely go?
Was it how low can they go, or
How low can they go?
well, that's also, it depends. I mean, if you're using the hydroxyurea to treat myelofibrosis, then it kind of just depends. You know, some people who have a hemoglobin of 8 feel fine and they don't really care that their hemoglobin is 8, whereas other people feel symptomatic. So I think it depends on the patient. The level depends on the patient. If it's being used for treating ET or PV, then it's a little bit more restrictive because, you know, ET patients in general don't have anemia unless there's some other issue going on. So we're less tolerant of anemia that occurs in patients with ET, and certainly with PV, if we're getting to the point of symptomatic anemia, we've gone too far.
Roni, do you have anything to add to that?
No, I think it's very individualized, as Raajit said.
Okay. This is a long one. We often hear that ET patients can live longer lifespans with maintenance, but there is little published to help guide us on what to expect along our journey and what progression looks like, which we did talk about. What happens to our blood work in progression? What are the signs of drug treatment failure? And when should we consider changing drugs? Raajit, do you want to start, and then
Yeah,
we can ask?
it's again very individualized, right? There are, you know, I've taken on the care of patients who were diagnosed by other physicians in the late 1980s, right, who are still just, they're cruising, right? So I guess not everybody's journey is going to be marked by progression or symptoms or any of those things. It doesn't have to happen. And I think the genetics have really begun to tell us who are the people who are more likely to progress versus not. You know, I think that in general, in certain patients with ET need to be on treatment, and those are people who are at high risk of having a clot. Part of that is genetics, and part of that is their other, I guess, medical issues, as well as if they've ever had a clot. And the drugs that we use, this is sort of an open an ongoing debate. We use things like hydroxyurea or interferon, or there's an old drug called the negrolide. So we have multiple drugs that can be utilized for this. And the failure of the drugs, I think, is the question was asked, is really two things. Is the drug not controlling the blood counts, or is the drug causing toxicity? And either of those things warrant a change in treatment. So again, we have multiple lines of treatment for ET, and importantly, there's now trials of novel drugs for ET as well. Some of the drugs that we're using for other MPNs are being tested in trials for ET. So, you know, we even have clinical trial options now, which is an amazing thing. What does progression look like? Well, it depends. I mean, you know, the disease can progress into myelofibrosis and, you know, result in the symptoms we see, like sweats and fevers and the spleen getting large and the blood counts getting low. Very, very rarely ET can progress into leukemia. It's incredibly rare, 1% to 2% at most. That is, I think I've seen that maybe 3 times in the last 9 years. So that is incredibly rare, but it can happen.
Roni, did you want to add anything to that?
No, I think that what happens for the transplant world is mostly we see these patients as they progress to myelofibrosis when they start, you know, plummeting their counts. So we are, you know, a step after.
Right. So please don't think I'm ignoring you.
Oh, no, no worries.
Repeat these questions, because I will always turn to you and say, do you have anything to add? Okay, I'll start with Raajit. I am fully vaccinated, but do not believe my body has produced adequate antibody protection. Can you please offer any guidelines to those of us that are in areas that are beginning to open up and dropping the mask mandates that will protect us? Should we continue to wear masks outdoors and indoors?
Such an important question. We cannot have a conversation without talking about COVID-19 because that's just the world we live in. But so the thing is this. We know from certain blood malignancies that patients who've gotten vaccinated are not responding as well as we would like, meaning that they're not mounting an antibody response. And so this was described in a disease called chronic lymphocytic leukemia, when that data came out of MSK. And it looks like people with CLL, particularly those who are on treatment, are having a less robust response, in some cases not responding at all. And so there is a concern, and there is a reason to have a concern that patients with blood malignancies may not have as good a response. What I will tell you is there's no data to my knowledge that's out there about MPN, but at MSK, we actually do have an antibody test that tests for antibodies to the spike protein. So there's two types of antibody tests. One is to test whether you've been exposed to COVID. The other is to test whether or not you've made an antibody to the vaccine, and that is the spike protein antibody test. So we've been getting this now routinely on all of our MPN patients probably for the last 6 months, and we're going to put the data together and put it out there into the public domain. What I will say is the vast majority of patients that we have tested have mounted an antibody response, which is incredibly reassuring to me. But not everybody, right? And until we test people, we don't know the answer whether or not they're fully vaccinated. So I think that, you know, it's not an unreasonable thing if a test like that is offered where you are to ask your physician if they can do the testing for you. It comes with caveats because it's only testing antibody response, but what we also know about vaccines is that there's also a T cell response, and the T cell response is a really important part of immunity to COVID-19, it looks like, from studies of patients who've been infected, but also patients who have gotten the vaccine. And the tests that we have right now don't tell us anything about that. So even if the antibody levels don't come back above threshold, it does not, I don't think you can say safely that a patient doesn't have some degree of immunity. So this is still kind of a gray area. You know, I think, you know, when I talk to patients, bring this question up all the time: how should I be, you know, acting and behaving in public? It's an individual choice, right? And I think that's why it's helpful to know somebody's antibody response, because then they can have some confidence and say, well, I have antibodies, and so I'm okay to take some of these risks, like, you know, going into a store without a mask or whatever it is. I think that, you know, at the end of the day, it is reasonable, if you're concerned and you don't know the answer about your antibody test, to continue to do things like social distance and wearing masks. We know those things work. And, you know, if others are not doing it, it is what it is, but that is something you can control, right? Number one. Number two, the vaccination rate keeps increasing across the United States. And as more and more people get vaccinated, this is going to become less and less of an issue, because once the prevalence of the virus goes below a certain extent, the likelihood of getting infected is going to be, you know, really small. In New York City right now, I think the last time I checked in Manhattan, the prevalence positivity was like 0.22%, right? So it's incredibly low here. And the vaccination rate is, I think, in New York State, at least approaching 70%. So those things are going to keep getting better. And I think even if somebody doesn't have a good antibody response, they're going to get protected by virtue of everybody else being protected. But the interesting segue here is Roni deals with post-transplant patients who have this as a chronic issue. So she probably has better insight.
Yeah, I think, as you said, this is the question we're being asked all the time. So as Raajit said, we've been testing actually systematically on our patients, and we continue to test with the idea that we also want to see what happens to a patient who got the vaccine at 6 months and at 9 months and at the year after getting the vaccine. I absolutely agree that there are more unanswered questions than answered ones, because I think just having the immune system is so complicated, and just having, the antibody doesn't mean that it gives us, to patients, particularly post-transplant, but also for patients on various treatments that basically manipulate the immune system, like chemotherapy, having a response to the vaccine, I think it's difficult to say if it's as protecting as for someone, or all the people who were in the studies that obviously were not patients with history of blood cancers, not patients on treatment. So I do tell my patients that it is reassuring to know that the immune system was able to mount a response, but to keep with the masking, particularly when they go to areas that they have no control of what others are doing. I think if they have small gathering and they know that everyone else is vaccinated, the risk is extremely small, whether they mounted a response or not, because the rest of the vaccinated people are again at extremely low risk to get it. But I think that overall, I tell my patients, even that they got the vaccine and they have antibodies, that in situations like going to the store or being in a public area, to keep the mask, at least at this point.
And I do when I'm in the store, especially, but
let me just follow up with one thing based on Roni's thoughts, right? I think the other thing to keep in mind here, right, is that the vaccines are extremely effective at preventing death, right? I think that has been the overwhelming message. Do people still get sick with COVID? Occasionally, yes, not a very high percentage, but they do. And I think my concern at the end of the day, still with our MPN patients, is that thrombosis is something that we know has been a major factor in morbidity and mortality from COVID. And so, of course, our patients, we tend to think they are at higher risk because of their MPN. So I think, even if you're vaccinated, you could still get sick. It may not be life-threatening, but could there be consequences? Of course there could. So I think caution is absolutely still advised.
And I actually heard a physician say, COVID is a blood virus. It's a blood disease or blood virus. And, who knows? I mean, I'm not a physician or researcher, but all right, moving right along. What percentage of allele burden can cause progression from PV to MF? Raajit, do you want to start?
Interesting question. I don't think that there is a cutoff. It's a continuum. And so if you kind of think about it as a continuum, as the variant allele frequency of JAK2 in particular goes up over time, the correlation with myelofibrosis goes up. So it is clear that patients with a higher allele burden are more prone towards myelofibrosis, but there isn't really a set cutoff that we know of that says at this percentage it's MF.
Does the antiviral property of interferon interfere with the potential of the antivirus live vaccine? And I might be pronouncing that wrong. I'm reading this wrong. ADEN, adenovirus?
Oh, the adenovirus vaccine.
Adenovirus, yeah.
Wow, that's a tough question. I have no idea. It's a really interesting question, right? Because the adenovirus is an attenuated viral vaccine. Unlike the mRNA vaccine is not a viral vaccine. It's mRNA, which makes the body produce the proteins that we want it to target, whereas the viral vaccine is a virus, right? It goes in and infects cells. But would interferon reduce the effectiveness? It's a really great question. I don't know the answer to that.
Roni, do you have anything?
Unfortunately not. I mean, I think that potentially some of these patients will be collected in our database because part of the thing that we're doing with our patients that were vaccinated is we're looking at what medications they're on around the time that, they've been vaccinated. We're also looking at their markers for their immune system specific T cell population and B cell population. So I'm hopeful that, in the next couple of months, we will be a little bit smarter in the ability to say what kind of treatments have effect. Again, it will only be on yes or no, you have antibodies with response to the vaccine, but I'm hopeful that we will be a little bit smarter. Again, at the end of the day, it will be very small population of patients on specific medications, but the only way is to collect this information and learn from it.
Okay. Is there a way to differentiate symptoms such as fatigue or leg pain as a sign of progression or a side effect from a drug? In this case, Rux, but any meds. Raajit?
But yeah, that's a really, it's also a difficult question, particularly fatigue. And what I always tell patients is that fatigue is always multifactorial. It's you try to figure out what the predominant driver of the fatigue is, but it's very difficult. In some cases, it becomes obvious, right? If somebody has been is not on any treatment and they're recently diagnosed and everything else looks like it's progressing and they feel more tired than fine, I think that it's reasonable to assume that it's related, but it is a difficult assessment to make. And sometimes, sometimes medications can be the culprit, right? And some of the medications that we use for MPN treatment sometimes actually are the culprit of the patient's symptoms. And sometimes what we do in those circumstances is to do what we call putting patient on a drug holiday, right? We just stop or discontinue the medication. And if things get better, then we say, fine, it was probably related. But there's no empiric way to know, whether it is related or not.
Roni, would you agree with that?
Yeah, and I think we always need to remember that the patients know themselves the best. And, if a patient know that they have been on a drug for a while and they see a change, or if they started a drug and they notice a big change. So even if we go back and we say, it has been reported like that, at the end, it's very individualized, and I agree with Raajit that at times that we are unclear. Taking a drug holiday is important and can help us with that.
So this is a question that comes up all the time, and I always, when I talk to our industry partners, say, can't you come up with something? Now, some of the drugs do help with this, but the pruritus and the itching, it's what is the phenomenon about this, this horrible itching experience, and is there data that explains it, and what eases it? Raajit?
Yeah, that can be a really difficult problem for patients, right? And we think it's because of the cytokines, the inflammatory cytokines that are released as part of the disease. But one of the things that's really strange is in some people, it is like absolutely the most pressing symptom, and in other people, it's not even an issue. Both the disease can cause it and treatment can cause it. We know interferons, pegylated interferons, can cause itching. That is actually one of the more common side effects with interferons. In general, my experience has been that the JAK inhibitors are really terrific drugs at controlling the itching, not in everybody, but in many, many patients. We try other things like antihistamines, occasionally like antidepressants. Sometimes they work, many times they don't, but in my experience, the JAK inhibitors have been really good drugs for that.
Okay, I was diagnosed with polycythemia vera 1.5 years ago, and am treated with aspirin and phlebotomy. I now have iron deficiency, anemia, and am concerned that I may have progressed to post-PV myelofibrosis. My uric acid and LD are normal, and I have no symptoms. I have never had a BMD. Other than a BMD, how do you know if you have progressed? A bone marrow yes.
Yeah, I think here a bone marrow is absolutely essential. That's the only way to make the diagnosis if there's been progression. I think, that's one of the reasons I tend to, when I meet a new patient who appears to have polycythemia, meaning that they have a high blood count and they have a JAK2 mutation, I tend to advocate to do the bone marrow because, you can sometimes, if the blood count's high enough, you don't really, per WHO criteria, need to do the bone marrow to make the diagnosis. On the other hand, when we think about a patient's course in the long term, it's hard to know where you are if you don't know where you've been. And so I think that if we do the bone marrow in the beginning, we know where somebody is. And if they have fibrosis in the bone marrow, even if they just have PV, they're more likely to progress to overt myelofibrosis. And if we do a bone marrow when there's a concern for progression, then we have something to compare it to. But I think the basic answer to the question is a bone marrow is the only way to know.
I hate to say this, but after 17 years in this field, you kind of start to know who the physicians are treating some of the patients too, if that's appropriate to say here. But anyway, okay, so this person has had polycythemia vera for 30 years. What is the probability of progressing to MF after beyond this 30-year mark?
It's depends on a lot of things. I think one of the things we know is that the genetics are beginning to tell us a little bit about that, and there are certain mutations that seem to be more associated with ET or PV patients progressing. There's some nice work that's come from the Mayo Clinic group, Dr. Teferi's group on that. So I think that tells us to some degree what the risk is. But again, we always have to distinguish between assessing risk and predicting. And predicting is something we can't do because we just don't have enough, I guess we don't have enough knowledge to be able to predict. We can't say to somebody, this is going to happen to you. The only thing we can say to somebody is there is some degree of possibility that you may progress, and it's based on X, Y, and Z. So I don't think we can give you a number on that. But the fact that things have been stable for 30 years by itself is somewhat reassuring.
So this is an interesting question. This person is interested in hearing more about current research and perspectives on non-driver mutations, allele burden, and their influence on progression and disease course. We kind of touched on the allele burden part of this. Roni, do you want to address this first?
So I think that this is still in early stages. A lot about the next gene sequencing in myelofibrosis came out in the past couple of years with nice work, both from Europe and in the United States, from collaboration of between centers. I mean, we know that there are certain mutations that are associated to be high risk for disease progression, but do not necessarily predict for transplant outcomes. So I think that's an important information that we saw in an analysis that Raajit and I led with other centers in the United States, and we're actually expanding that. However, I'm looking at this mostly from the transplant aspect of it. I think Raajit can probably tell more about how he uses that to decide about yes or no initiating treatment and specific treatments.
Raajit?
Well, right. So I think this is an important thing. And what has changed is that we used to do prognostication just based on clinical variables, right? And now that is completely changed because we have new tools. We have something called the MIPS, the molecular international prognostic scoring system, where we put a patient's mutations into our calculator and we can actually say, probabilistically, this is the chance of progression. And that's amazing. I mean, I think that's such a valuable tool. We always have to take it with a grain of salt because, again, it is not a prediction. It's a probabilistic statement. And so, yes, that we know that mutations outside of the driver mutations do play a role. Just for clarity, the driver mutations are the JAK mutation or the calreticulin or the MPL mutation. And there has been a clear association that other specific mutations in genes called ASXL1 and SRSF2 and IDH1 and 2 and EZH2, and now more recently mutations in something called RAS. There's something called KRAS and NRAS. Those all appear to be heavily associated with the disease progressing to leukemia, myelofibrosis progressing to leukemia. So those are valuable tools. And what's the biologic proof? Well, the biologic proof is in the mice. If you take mice with a JAK mutation and you introduce an ASXL mutation, many of them will get leukemia or their disease progresses. This is work that's published from the group in Miami. The same thing is true in IDH mutant mice if they have JAK and IDH. So we know that some of these mutations certainly progress the disease. We always worry about mutations in a gene called P53, which is known as the master regulator of the genome. It is, I think, the most common mutation in cancer, human cancer in general. And we know clearly from work that we've actually done here that if you combine an JAK mutation with a P53 mutation, the mice get leukemia, but if you look at the human data, the same thing is true. So those other mutations are important, but the situation we're always faced with is that we meet a patient, we do their genetics, and we say, well, you have these high-risk mutations. What do we do with that information? And maybe then this might be something, a good jumping off point, right? That's where things get a little bit tricky, because if we see that somebody has high-risk mutations and they're otherwise okay clinically, they feel, well, their spleen isn't so big, the question is, what do you do, right? And my take in that situation is always to be prepared, meaning that if I see that, then the next phone call I'm making is to Dr. Tamari to say, please see the patient and we'll plan the transplant out and think about it. But is that enough information for us to act and say, well, Roni, please transplant this patient tomorrow if you're free? No, that's where things get gray. And the advice that I think both of us have always given patients in that circumstance is really close monitoring. And when we think that there is some evidence of progression, early progression, that's usually or often enough for us to say it's time to go to transplant. But what the mutations, from my perspective as a non-transplanter, are sort of the canary in the coal mine. If I see the really high-risk mutations, it makes me take a step back and say, we may be dealing with a problem and we need to try to head this off, which means we need to be extra vigilant. But I'll sort of have Roni chime in here, I guess.
Yeah, I absolutely agree. And that's, I think, goes back to where we started when I said we really need more information about that, because we know, and there was recently a very nice publication that looked at transplant outcomes according to the DIPS, which doesn't take into consideration the mutation and the information. And we know that if we transplant patients too early, we're actually not helping them. However, for patients with more advanced, we are definitely improving their outcomes, but that doesn't take into consideration the molecular mutations. And what do you do with patients who have high-risk molecular mutations, but they're actually doing well? They're not transfusion dependent, they don't have symptoms. So if transplant wasn't as easy as doing, an appendectomy, sure, easy enough, let's just do it and cure you and we're all happy. But the other side of it is that, we're not there yet with transplant. So it's a very, delicate and fine line to make that decision. And I absolutely agree with Raajit. We do want to know about these patients on the transplant side. We do want to be prepared because many times we cannot just transplant within a week or two. We need to find the donor. There are some maybe other medical issues that we need to address. But for patients who are doing very well and have high-risk mutations, these are the ones that we want to monitor closely and maybe look at, their next gene sequencing more frequently to see if also there's a pattern of change in the mutations. Are they having new mutations and there's change in the variant allele frequency, things that will lead us to say, this is the time to move with a transplant.
Thank you. Is there a better form of interferon about to be approved from Europe? And I know Ropeg interferon from Pharmacentia, who we will hear from later on today. But Raajit, do you want to talk about Ropeg? I'm assuming that's what they're talking about.
Yeah, that's my assumption. I mean, Ropeg is approved in the European Union, and my understanding is that it's under review at the FDA. I'm going to defer to our colleagues at Pharmacentia to provide details about all of that. But I think that from a treating physician standpoint, we are really looking forward to having that drug at our disposal to treat patients.
Okay, let's see. Are ACE inhibitors for hypertension recommended for PV? I've heard this question before, actually.
I'm not sure why they would be recommended or not recommended. I'm not sure that there's a clear, as far as I know, clear impetus to choose or not choose ACE inhibitors in the context of PV. I don't know.
Okay. Well, let's move on. I have ET, very high platelets. Recently, my white blood count increased and I read to decrease white blood count and by taking vitamin C. What strength of vitamin C should I take?
I'm not aware that there's any data to support that vitamin C changes the white count.
Let's see, I am 90 years old. I hope I can say that if I'm sitting here. I am 90 years old and take baby aspirin daily. Years ago, my doctor prescribed drugs to reduce platelets, but my sensitive stomach could not take it. Is there certain food I should avoid or add to my diet that increases my platelets?
That's a common question that we get from a lot of patients. Are there dietary things one can do? I don't think that there's a direct or good answer at this point. I don't think that we have data to support that. What I will say is that my colleague Angela Fleischman, who's based in California, physician scientist, she's studying the effects of diet and inflammation. And her hypothesis is that diet contributes to inflammation, which we certainly know from cardiovascular literature, and that might change patient symptoms, maybe even change clot propensity. So she's actually studying this. And she actually has a program online where patients can register and go on a Mediterranean type diet to see if that modifies their symptoms. So it's a good question and something that's being researched.
We heard this in previous programs, and I opened my big mouth about it also about anti-inflammatory diets, and I'm Mediterranean almost 100%. Almost. And, I've been eating like this most of my life, but it doesn't mean I'm the picture of health either. I've had my issues, but an anti-inflammatory diet, and Dr. Fleischman and I have talked about this too, but would either of you like to address that? What are your thoughts about a Mediterranean diet? You kind of just addressed that, but.
Yeah, I mean, I think look, she's studying it, and we need the information to understand what what practical implications it can have. But I mean, again, at least from the cardiovascular literature, right? I think, I guess the way I would think about it is this, right? When I talk to somebody with ET or PV, what I always say to them is that you have to think about yourself like somebody who has diabetes or has heart disease. You have an increased risk of clotting. And what would I say to somebody who has diabetes or heart disease? Well, I would say you need to change your diet and, don't start smoking, and all of the things you would say to, common sense things that you would say to somebody, and diet is included as part of that. So I think that that's an important question. And I'm sure Dr. Fleischman's data will yield some really interesting and promising results. But I think as a general principle, adopting a heart healthy diet, which in many cases is anti-inflammatory and Mediterranean diet, is a reasonable step to take, and we'll see what her data shows.
Okay, this patient suffers from chronic fatigue. Is there anything that helps, and are there any drugs that can slow the progression of the disease? We kind of talked about that, but let's talk about fatigue. As we know, it's the #1 issue with our patients. There have been fatigue studies, lots of information out there. I think what our patients need to hear from both of you is, and I've learned this over the years, that it's the fatigue is not fatigue that I suffer from. I can be exhausted from a long day. I can be exhausted from a long travel day to other countries. I can be exhausted from a lot of things, and I can just crash in my bed and sleep for 9 hours. This fatigue is very different. And so could you address that? Roni, do you want to start?
Yeah, I absolutely agree. And to me, this goes together with a very, what we call inflammatory milieu. And it's something that we also see post-transplant. And this is not specific to MPN patients, but I do tell my patients, when you leave the hospital after a transplant, this is a fatigue that is interfering with your ability to function. It's almost like you have a fog on your brain. I wish we had a better objective measures to assess that, which I'm not aware on very useful clinical tools to assess it. I do see that, when I just compared, years, I can see patients who came to us in the pre-Jakafi era to post. I think that's one drug that definitely helped with that. And that, brings me back to the issue that this is mostly cytokines and inflammatory markers associated with that. In terms of other drugs, I'll defer to Raajit to discuss more about that.
I agree with everything that's been said, right? When you actually talk carefully to patients about fatigue, I think that's exactly the history you get. There are different types of fatigue, right? Patients, sometimes it's from anemia, sometimes it's from disease, and sometimes it's just from other things going on in life, but they're all different. And that there is a subtlety there that I think is so important to pick up with. And the only way you do that is by talking to people carefully about that. This is also one of the most difficult problems because there's no easy fix for fatigue, particularly if it's disease related. Sometimes medications make it better, right? Sometimes the JAK inhibitors do give people the lift that they need. And in other cases, we have a pretty strong supportive care service here, and when we refer patients to them, they lump it under cancer-related fatigue, which is a kind of a broad diagnosis, but we see this across different cancers, and they do try different things, and sometimes they try antidepressants, sometimes they try drugs like Ritalin, which have been used to treat kids with ADHD, but they are used to treat cancer-related fatigue. Sometimes people can tolerate it, sometimes they can't. It makes people a little bit jittery. So there are some pharmacologic things that we can do and try, but it's a difficult problem. There's no question.
Is there any evidence that suggests that Pegasus in small doses can keep ET at bay?
It's an interesting question too. I mean, keeping it at bay, does Pegasus control the disease in terms of controlling the blood counts? Yes, there's abundant data with regards to this. Can it actually prevent progression? We don't have any randomized trials that speak to that data. There is retrospective data that's come out of our colleagues across the street at Cornell, very recent data actually, where they've looked at this question, and at least their data suggested that there may be a delay in disease progression, but it's retrospective data, but a large number of patients. So we don't really have any prospective data to tell us whether or not it can. I think that the indirect evidence is that we see that there can be a decrease in the mutation burden in patients, and so does that directly translate into preventing progression? I'm not sure we can say that, but there's zero question that interferon is a very useful drug in ET.
Okay, I'm going to direct this to Dr. Tamari. What are some of the advancements in transplantation with regard to prevention and treatment of graft versus host disease and infection?
Oh, that's a very good question. So I'll start with infection. So I think when we think about transplant, we know that the way transplant works is that we kind of wipe out the patient immune system and we introduce a new immune system. But in order to prevent graft versus host disease, we need to give medications that are immune suppressive. So the patients are very immune compromised for a long time. And while in the early stages post-transplant, we mostly deal with bacterial and fungal infections, for a long time after that, we're talking about viral infections. And many times it's actually viruses that we've all been exposed to. So it's the common ones is cytomegalovirus, Epstein-Barr virus. So a lot of very important advantages. One of them is treatment for prevention actually of CMV reactivation. So there's an approved drug called letermovir that really changed outcomes for transplant. So about 7 years ago, I would say that 50 to 60% of our readmissions after transplant were for treatment of patients with CMV. That reduced significantly, and definitely that trend translate to improved transplant outcomes. GVHD also, we have more drugs. We used to have steroids as our main treatment for GVHD. It's still a very, very important drug, but the approval of Jakafi is very significant because while steroids are very effective to treat graft versus host disease, they come with a large price, unfortunately, whether it's hyperglycemia, diabetes, deconditioning. Now that we have Jakafi is steroid sparing, that has improved significantly outcomes of patients with GVHD. And there are other drugs now that being studied and with good efficacy. So we definitely see that both for infectious prevention and treatment, similar to GVHD, the field is moving forward in many active trials and promising drugs.
I'm curious about this as well. Please explain the NIAID COVID vaccine study. Are either of you familiar with that and when the results would be in? I'm not sure that, I remember some discussion about this on a previous program, but I'm not really, I'll have to look for that and put it on our website. I'm fully vaccinated with Moderna, but tested negative for COVID antibodies, probably due to Jakafi. What are your thoughts on stopping Jakafi for a short time and getting the Johnson & Johnson vaccine and then getting back on Jakafi? I'm assuming we're not going to get boosters for 6 months out or a year out. You know, nobody knows at this point unless one of you has been, has the answer to that. Raajit?
That's a tough one, right? I mean, Gabe, we're kind of right at the edge of our knowledge here. And I mean, the whole question about are boosters going to be required, it's unknown, right? There was some data that had come out that suggests that maybe we won't need boosters because this could be for the mRNA vaccines a very relatively long-lived immunity. I don't think we know the answer to that. The question with regards to Jakafi, I've seen this, in a couple of our patients. Most of our patients who are on Jakafi have had an antibody response, but not everybody. And this question has come up in our minds too, but right now there's nothing that we can recommend because there's no data and we just don't know, because there are, as Dr. Tamari was saying earlier, the immune system is very complicated, and is it the Jakafi or is it some other issue? We just don't know.
The only thing that I may add is that
Yes.
maybe it's the timing, and maybe, I don't know how soon after the second dose it was tested. So I think it's worse if it was done early to maybe repeat the antibody test and see if there was a delayed detection. That's the one thing that we've seen with a few patients. So I think that's worth doing if possible.
So, for our partners that are out there, industry partners that are out there, will MF drug trials ever consider including patients that have a minor or second blood cancer, for example, CLL? I thought there were some trials like this, but I could be wrong.
I think that's always a really difficult issue. In most cases, having another cancer, unless it's a really low-grade thing like a prostate cancer, doesn't have to be treated, or a skin cancer, or sometimes a non-invasive cervical cancer. Those are all things that will many times they'll allow patients to enroll, but for other concurrent diseases, it's usually exclusionary.
Okay. Let's see, we've got several pages here. Is it true that there is less proof of bone marrow reversal improvements in CALR patients as opposed to JAK2? Raajit, I'm not sure I understand this question.
Yeah, I'm not sure I understand.
Huh. Okay, we'll wait on that. Is it necessary at 60 with ET and CALR to start medicine if, I guess, your platelets are under 850?
It depends. I mean, so it used to be that everybody at 60 would need medication, or we would recommend medication, but we know that patients with a type 1 CALR mutation, there's two types, don't necessarily need medication at age 60. So we used to group people into low risk and high risk, and now we have very low risk, intermediate risk, and high risk. And patients with calreticulin type 1 mutations who don't have a clotting history and don't have any other major cardiovascular risk factors go into that intermediate risk category. in which case you don't necessarily need to start treatment.
Roni, did you have anything to add to that, or are you good with
No,
that?
no.
Okay. So this is a good question. Pegasus and conventional interferon have been used in ET patients. Why is Rho-peg interferon only being approved for the use in PV patients? And will its properties be beneficial for ET patients in any way?
Yeah, it's a great question. The reason that it's being approved is because that's the study that was done. So it was a phase 3 study that was exclusively in PV patients, randomized versus hydroxyurea. So they didn't do a phase 3 study in patients with ET. That's what's really usually required for the approval of the drug. Now, is it obvious? It's obvious that the drug should be studied in ET, and I think there are plans to do that. But again, I'll defer to our pharmacentia colleagues to talk about that a little bit further. So it's really just, it's a regulatory issue, but the clinical need and the biological rationale are absolutely there.
Do you believe the Manifest drug will be approved by the FDA? And if so, when do you think that might happen?
I don't know that, nor do I know the winning lottery numbers for tonight. But I guess what I will say is that the drug is promising, right? I think all of the data that we've seen so far is really promising. And now there's the phase 3 trial, which again, phase 3 trial, just I guess to backtrack and make sure everybody's on the same page, right? In a phase 1 trial, we put a drug into people for the first time. It's been studied in animals and it goes into patients, and we try to find what the safe dose level is. In the phase 2 study, we tried to find out, does the drug have any efficacy, meaning that does it have a clinical response? And then in phase 3 studies, what we're trying to determine is the drug better than the current standard of care? And that is the trial usually the FDA used to approve a drug. So the BET inhibitor that's been studied in the Manifest trials has been studied in phase 1/2, and it clearly looks like patients are having responses, but it's been used as a single agent or in combination with ruxolitinib. So the phase 3 is now the definitive trial, and that has just started to accrue throughout the world. And that will give us the answer to the question that's being asked, because if it is superior statistically, then that would give the FDA impetus to approve the drug. So we don't know the answer yet. And I have to say, look, in the history of drug development in oncology, we've seen many cases where drugs look great in phase 1, and then they get to phase 3, and they flame out. They don't prove the statistical benefit. I don't think that's likely to be the case here, but we have to wait for the phase 3 data.
So, I want to address this question for a couple of reasons. The person is asking, how do I reduce the anxiety I feel with this new MPN diagnosis? And what we've discovered doing these conversations with the specialists is we're getting quite a few new patients at these programs. And so, just from our perspective, we are here for you. We provide a lot of resources and can direct you to resources. We can direct you to some fabulous MPN specialists like those with us today. But on a medical, from a medical standpoint, we're talking about, we will be there to listen to you. We can provide some of the soft things for our patients. But from the medical side, when a patient is newly diagnosed, it's a big thing. There was a scare almost a year ago for me with cancer. I thought I was going to handle it so well and be so gracious, and I don't care, I can do this. And it was a tough month. It was a very scary month. Our patients have a chronic blood cancer, and so it's not going away in a month. So Raajit, do you want to address that? And then Roni.
This is a really common situation, and particularly with newly diagnosed patients. I agree with you. It is, in many cases, it's more difficult to deal with the anxiety with this than somebody who's diagnosed with an acute leukemia, because it's there and you need to deal with it right away and it's done. And in this case, in many cases, we're saying to patients, we're not going to do anything. And that doesn't always sit well, because someone says, well, you've diagnosed me with a blood cancer and you're not doing anything for me, and it might get worse, and it might turn into leukemia, it might turn into myelofibrosis, and you're telling me there's no way to prevent those things from happening. And the bottom line from all of that is one of the principles I think is true that I've learned in my career is that uncertainty creates anxiety. I think that is absolutely true. And can we, we have no crystal ball. We can't say to somebody, this is going to be your outcome. This is, with absolute certainty. What we can do, and what I think is beneficial to patients, is to do our best to arm them with knowledge. Because when somebody gives you this heavy weight of diagnosis and you don't know the ins and outs, and you know some statistics about what may or may not happen, that to me is a huge driver of anxiety. So I think our job, I think an important part of our job is to do our best to educate the patients as much as possible about their disease, both in the clinic when we see them, when there are patients, but also through forums like this. And that I think in many cases does help to reduce the anxiety. Certainly, I don't think it goes away, and it's a difficult problem to deal with because again, it's always there in the background. And part of trying to deal with that is trying to help people learn how to live with their diagnosis. And live means carry out your life and enjoy your life. And if the anxiety is overriding that, you simply can't. I always talk to patients, not initially, if it continues to be a problem, about working with our social workers and our psychiatry folks here. We're lucky enough, we're in a place like MSK where everything is cancer focused, and so our support, our social workers and our psychiatrists are all they do is they deal with cancer patients, and so I think those things help some patients. But again, not everything is for everybody. Not every patient is going to respond well to having counseling or therapy as part of their treatment plan. Sometimes people need to be on medications, and that's okay. I mean, sometimes that is the best thing for a patient. It just depends. But I think our principal job is to arm people with information. I think that's a powerful tool.
That's exactly what I was going to add to your beautiful answer to this question is remain educated, remain engaged. There are people like us out here that will listen and try to get you through a bad moment, and but educate yourself. Absolutely, that's why we're here. Roni, did you have anything to add to that?
No, I absolutely agree that it's about the knowledge and information. And I think, we tend to use words, and many times they have a lot underneath. So even we can see that we are talking MPN and you think, okay, this is pretty narrow. And even within the MPN, we see from all the questions, it's very heterogeneous. So, essential thrombosis is not the same as myelofibrosis. They're not the same as PV. And even within them, we have the ability with the information to understand a little bit better what it means for each individual. So I think that, as Raajit said, and exactly as you said, Anne, reach out, ask, where am I standing on this spectrum? And really, I know that, it's scary altogether, but the more you know, the more you understand where you are. I think that's the key.
I agree. So can MPNs cause back pain? Raajit?
Sure, I think for sure people can get bony pain from it. Very occasionally, patients can experience what's called extramedullary hematopoiesis, where the spleen enlarges in part because there are cells from the bone marrow that take root in there and start growing. That can actually happen in many other places, like the back, like the lungs. So the answer is yes, it could.
We kind of touched on this. Let me look. That's quite a long question, so I'll wait on that. Could it be appropriate for a patient who is transfusion dependent on Jakafi and Donazole to add or switch to Pegasus for the Jakafi?
It's been studied, the combination of Jakafi and Pegasus. I think right now it's certainly not a standard regimen that we would recommend, but it has been studied. It does appear safe.
Does variant frequency levels for high-risk mutations correlate with the rate of risk for transformation to AML?
That's a really great question. So just to kind of frame what the question's being asked is that there's something called the variant allele fraction, which is the kind of essentially percentage of a mutated gene versus the normal gene that you have in the blood. And the question that's being asked is, as that number increases, does that correlate with the risk of disease progression? I don't know that we know this for all the mutations, but for certain mutations, the answer is yes. So when people have something called a P53 mutation, which, as I said, something that we worry about when we see it, we know that there's actually good data that in people who have a really low variant allele fraction of it, in the short term, meaning 5 years, it doesn't seem to have any consequences. There's a paper from a group in Poland on that. But what we've been able to show and others have been able to show is that when that increases dramatically, that often does correlate with the disease progressing, and particularly into the leukemic phase.
So getting back to COVID information here, I mean, we're always going to see this. I have my own questions, but I'll save those for later. In the UK, AstraZeneca is not recommended for patients under 30 years of age, yet in some countries it is not recommended for under 55-year-olds. What is the best treatment option for MPN patients under the age of 30?
With regards to the vaccine type?
Yes.
I see. Yeah, it's a hard thing. There's no guidelines that I'm aware of currently to tell us what to do. I think that, you know, the important point is that the thrombotic events that occurred were extremely rare in the data that has been put out publicly with the AZ vaccine. So we always have to put that into some context. And I think the regulatory agencies in those countries are being really cautious about saying, you know, nobody under a certain age should get them. I don't know that there's any, you know, guidelines for MPN patients currently, and I don't want to make a blanket statement and say, well, everybody should get the mRNA vaccine. I think the principle should be everyone should get vaccinated, because again, that's the disease itself has a thrombotic risk. It's extremely rare though.
Do high levels of cytokines in MPNs such as INF-A, IL-6 come after inflammation, or are they responsible for the initial cause of inflammation?
That's a tricky, subtle question.
That's an excellent question.
It's a great question. I think that our thought is that they are the drivers. What's instigating that? Is it just having the JAK mutations? Is it something else? That's what we don't entirely know, but they are part and parcel of the inflammatory process.
Roni, do you have anything to add to that?
No, I agree. I mean, I think that we don't look at them as the initiating, we see them, but to exactly know what, you know, initiates, what's the consequence, we don't know.
This is for Roni. What are the factors that go into performing a stem cell transplant with a reduced intensity regimen? Also, what are the factors in choosing to perform a haploid versus non-related matched?
Oh, great questions.
Can you explain what a haploid, you know, just so our viewers will understand what that means?
Sure. So we consider a family member who is half a match to their recipient as a haploidentical. What do we mean by that? So when we do a stem cell transplant, we look into having the recipient and the donor. We look into how they look similar or different with regard to their immune system. So haploidentical is a family member who is half a match on the factors that we consider for the immune system compatibility with each other. So most of the data in transplant patients with myelofibrosis is actually with match donor. I think we need to remember that there are very, very few prospective transplant studies in patients with myelofibrosis, and most of our data is retrospective, meaning we go back and we look at all of our patients who are transplanted and we try to understand these factors. How does donor selection affect outcomes, the conditioning intensity, etc. So for many years, really only patients who had HLA matched donors were considered for transplant. And only in the past couple of years, what is considered alternative donors who is haploidentical and either cord blood units are coming into play. I think, there was recently an ASH abstract from Hopkins looking at haploidentical donors that reported actually very similar outcomes to what we see with HLA matched donors. I think the caveat here is that when you compare a single center to a retrospective, there is certainly a selection bias. So I think that until we study that in a prospective way, we can't really say. However, not everyone has an HLA matched donor, and I think that there's enough data to say that we have outcomes and we can cure myelofibrosis using haploidentical donors. I would say that here at MSK, our donor selection is still to look for HLA match donor and haploidentical after, and we will not prioritize haploidentical over HLA match donors. But as always, it's an individual decision. Let's say we have a haploidentical who is very young and healthy and the HLA match is not, then we would use a haploidentical donor. With regard to the condition intensity, so I think this comes from actually old data where in the past transplant were done with high intensity regimen using high dose total body radiation, and that was associated with worse outcomes with regard to mortality from the transplant, what we call non-relapse mortality, meaning the patients actually cured their disease, but they didn't survive the transplant. We moved a lot from using high dose total body radiation when we use conditioning for patients with myelofibrosis. Most transplants are probably still done with a reduced intensity because the median age of patients with myelofibrosis, they're mostly older patients in their late 60s and early 70s. However, again, with not using TBI, some of the even more what we call myeloablative conditioning are better tolerated, and the decision is individualized to the patients, considered, what their other medical problems are. So again, very individualized decision.
Thank you for that in-depth response. That was great. Is hydroxyurea my only go-to drug starting out for CALR patients?
Well, I think it depends on what the disease is, but none of the disease I can think of is the choice of medication specific to CALR. So the answer probably is no.
I like this question a lot because we now know we have started a program for pediatric MPN patients, and that number is growing exponentially. And so should the criteria of the WHO for adult MPN patients be used for young patients? Are there any problems with that? And, in talking to parents whose children are being prescribed large doses of, the same dose as an adult for some of these, with some of these meds, I can tell you that my heart aches for them because, it's just such a crazy time. But your thoughts on this, Raajit, you want to start?
Yeah, so I go back to, one of the things they always, when we are in medical school and we rotate through pediatrics, one of the key principles we're always taught is children are not small adults, right? That's an important message. And it means that their physiology is different. How you dose drugs is different. So I think that, the answer is we have to think about that as a separate problem, that we should not group adults with MPNs and children with MPNs together. I think we have to think about them separately. And obviously, as you know, my good friend and colleague, Dr. Nicole Kachin at Cornell, this is exactly what she's studying. This is the question that she's trying to figure out and trying to, I think, change how we think about this, particularly in children. No, absolutely.
She's our partner in those programs. So yes, and we know she's doing great work. Have you seen patients with ET who develop polymegalia rheumatica as a I'm going to screw this up royally, but paraneoplastic syndrome?
I have not, which doesn't mean it can't happen. A lot of blood malignancies can be associated with paraneoplastic syndromes. There are other blood cancers that are well known to do that. I haven't seen it directly, and I'm not sure what the literature is, but it is plausible, I guess is what I can say.
Roni, do you have a percentage of patients over 65 who receive a successful transplant, and what is the risk that they carry, at that age? Does it still stop at 70? It used to stop at 70, that's no longer.
So I think that there are certainly some transplant centers that have age limit. Here at MSK, we moved from that, and we actually, age is certainly a factor, but it's not the only factor. Overall performance status is really critical, other medical issues. We actually gathered with our geriatric service, and we look, in depth into that of how to improve outcomes in patients. And I know geriatric is not, so I'm going to say maybe the older age. And we have assessment by this service before transplant to really better recognize if there are issues, because I think one of the things that we learn is that, when we see patients in the in transplant clinic pre-transplant, we have a snapshot, right? We see the patients for maybe 20, 30, 45 minutes, but that doesn't give you the really details of what happens, actually out of clinic, the ability to function, which can predict for outcomes post-transplant. So it's not age per se, it's age, performance status, and detailed assessment for that age group. But certainly we're not, there's no age cutoff.
If I take a break from taking Pegasus, will my platelets lower or go higher than they were before taking Pegasus? Raajit?
Unclear. There are actually, it's an interesting question because it was data presented at ASH last year that suggested that some proportion of patients who are on Pegasus might be actually able to discontinue Pegasus and have and maintain the response that they've had. So it seems to depend on how long somebody has been on Pegasus and what extent of response that they've gotten, but things may not change at all coming off of Pegasus.
Okay. Are there, I like this question because I think there are some gray areas here, but what is the adequate amount of antibodies that one should have for the COVID antibody test?
I don't know that I don't know that I know the answer to that, but I'm not sure there is a clear answer. The tests that we use titers, and so they tell us if it's above a certain level, it's positive, if it's below, it's negative, and they give us a quantification. I think there is some data that I know is out there that people have looked at from patient samples, not MPN patient samples, but patients in general, to kind of identify how much antibody you may or may not need. But I'm not sure that I can give you a distinct answer at this point.
And I also believe there's variability between the tests, so we need to be also mindful of that.
If you have a comorbidity that can on its own cause higher platelets, is there evidence to show that drug treatments for those issues, such as migraines, will bring down the platelets?
Well, I think that it depends on what the issue is, but if somebody has a co-occurring issue that does cause their platelets to go up, then we would aim to treat the underlying issue, right? A classic example is somebody who has iron deficiency, their platelets can go up, or people who have inflammatory or autoimmune phenomena, sometimes their platelets go up. So I think certainly trying to treat the underlying issue is important. That being said, in patients with PV, we don't generally treat their iron deficiency, but that's just an example.
Okay, this patient had their spleen removed and was curious how this could affect other diseases that they have, such as lymphocytosis and CMD.
Sorry, say that one more time.
This patient had their spleen removed and was curious how this could affect other diseases they have, such as lymphocytosis and CMD.
I don't know what CMD is.
That is.
I mean, taking the spleen out can cause there to be an increase in the white count and definitely the platelet count. So those are side effects of having the spleen out.
Yeah, I'm not sure what CMD is.
Okay, I need 2 units of red blood cells every 3 weeks. What are your thoughts on hyperbaric oxygen therapy chamber to help with anemia?
I'm personally not aware of any data to support or refute that. I think, you know, the depending on what the underlying disease is, um, we talked about Procrit at the beginning, right? And that's a way to stimulate red blood cell production. Um, so the body does have sort of an oxygen sensing mechanism, which will tell it whether or not it needs more red blood cells. I'm not sure that changing the oxygen percentage will change that. So I'm not sure.
Okay. Roni, do you have anything to add to that? So we know that many of our patients have tingling and problems with their feet and hands and restless leg syndrome and all those things. But is there anything that can be done at home for the tingling and burning sensation in their feet? Raajit, do you know of any remedies after all these years?
One thing that I've tried with some success is having patients take aspirin twice daily, a baby aspirin twice daily. And now there's actually good data, biochemical data, to support the idea that that might do a better job of inhibiting the platelets than once a day. This is good data from our Italian colleagues that has been put out there. And now the question's been raised, should all of our patients be taking the aspirin as a twice daily regimen? But in the idea when patients are having these symptoms is that there are potentially multiple causes. If it's a neuropathy, something that's caused by a nerve injury, then this is not going to work for them. But if it is vascular, meaning that we think that their platelets are sticky and that's what's causing the tingling, then trying an aspirin twice daily sometimes can be beneficial.
So we've talked a lot about, diet but there's a lot of information out there about cumin. And of course I use that many times in my diet. But I remember somebody talking, maybe Dr. Kamaraju, talking about that not necessarily could be a good thing for our patients. And I don't remember the context, so maybe you could explain that.
Yeah, some of the dietary supplements can cause dysfunction of the platelets. We know that. And the other thing, they can also cause side effects, right? Because these are food additives that are not meant to necessarily be consumed in large quantities. Good example of this is resveratrol, right? This is in red wine. And so then everybody started taking resveratrol pills, but I mean, that's way more than you would get from drinking wine. The same principle applies here, that when you take something, when you take a large amount of any of these types of supplements, that can have negative effects. And, we do see this with the platelets in particular.
Okay. This is a really good question. How does Pegasus work? How does interferon work?
I don't know that we have a great answer. I mean, look, this is being investigated by a number of people and has been a topic of investigation for a number of years. I'm not sure that there's a clear consensus. Interferon signaling works through the JAK-STAT pathway, right? And so the thought is that it may change the pathway and change the disease. There are other hypotheses as well, but it is not something for which we have a very clear answer.
Okay, let's see. If an MF patient is on fedratinib and became transfusion dependent, are there other clinical trials or a different treatment they can possibly try?
It depends, because the thing is, in the first 3 months of therapy with any of the JAK inhibitors, we know that the blood counts are going to go down, particularly the red count as well as the platelet count. So if it's in the initial part of treatment, it's okay, and we can transfuse people and it will actually oftentimes get better on its own. If it's later in the disease course, if somebody's been on, fedratinib for 6 months and now they're getting a transfusion dependency, then I think you have to ask the question, why and what's going on? So I think the first question, the answer to this question really is you have to figure out why that's occurring.
We know that most drugs, I would say most, have some side effects of some sort. Not everybody experiences those, but are there any long-term effects of the use of hydroxyurea that you're aware of? And there are some studies out there, but Raajit, do you want to start? And Roni, if you've seen anything?
Yeah, this comes up a lot, right? I mean, we know certain things for sure. There is an increased risk of skin cancer with hydroxyurea, skin damage. So yes, there are there are some long-term consequences that can occur. The issue that always gets brought up is about leukemia. You know, does it cause leukemia? And this is something that is just been debated. I think there is debate in the literature and amongst specialists as to what the real risk is, if any.
Roni, do you want to add to that?
To me, hydroxyurea is usually a bridge just before, the patient come to transplant, and I use it just to try to get the counts down. So like some what we call cytoreduction. I think that the question of leukemia is a very challenging and difficult one because it's like, these are the patients that have the higher risk for that because they already have, an initial myeloid disease. So unfortunately, I don't know that this is something that will have an answer, the definitive answer in the near future.
So we have a few more questions here, but for the sake of time, because at 12:45, we have our industry partner updates. But I'd like to ask both of you to, share some of your thoughts and feelings about the future. I mean, I've been in the space for 17 years. I can tell you that I've never seen so much activity and so many good things happening in any disease area. And, it pleases me to no end to see all the interest in this blood cancer and these blood cancers. So could you share from your perspective what our MPN population can look forward to? Anything you'd like to share with them at this point? Raajit, would you like to go first?
Yeah, I agree with you. I think that this is an amazing time, right? And I think back to like when I started in this field in 2013, we had just gotten ruxolitinib, and then we had patients who didn't do well with it or it were progressed. And then what do you do? Well, there was some trials and some good rationale, and we're in a completely different space. What I say to people now is that I'm turning trials away, right? And I'm getting calls from collaborators and sponsors saying, hey, would you like to be part of the study? And I'm saying, I can't because I have too many trials. I almost have two more trials than I have patients who are eligible. But that's a great thing. I mean, I think it reflects a couple of things. One is it reflects that our understanding of the biology of these diseases has immensely changed in the last 5 to 7 years. Number two, there's more people getting interested in this field and wanting to explore it. And number three, the drugs that we have, the pipeline of drugs that are coming through from our collaborators in the pharmaceutical industry is expanding immensely. And not talking about just MPN specific drugs, but the types of drugs that are coming through for cancer in general. It's amazing, the type of targeted drugs. And so now the tasks are really to try to figure out, A, do these drugs work in our MPN patients? B, who are the right patients? And now I don't think that the future is that all MF patients are going to get regimen A. I think that we're going to begin to drill down and figure out which patients is a specific regimen right for. I think that's one of the big things that is hopefully going to emerge. I think that, as I alluded to earlier, the timing of treatment is an open question. And, instead of waiting for our MF patients to get really sick, can we stop that process? Is there a way to intervene in the ET and PV patients or even the early MF patients and to arrest the process so it doesn't get further? I think, in other cancers, we don't wait for things to progress to get bad before we start treating. We've done that in this field because really two reasons. One, we haven't had good drugs to do anything. And number two, some proportion of patients are going to do just fine without us intervening. But what is changing is we're beginning to be able to understand who the patients are who are going to do fine versus those who may have a problem down the road. And number two, we have now all of these new drugs in development that all look really promising and that we think could make a difference in the disease. So my expectation here in the next, let's say, 3 years is that the paradigms that we're talking about today are going to be completely different. I hope they're going to be completely different, but I think they're going to be completely different.
I agree. And Roni, would you like to share your thoughts?
Yeah, I mean, similar to Raajit, I think it's really amazing how different the patients that we see are. Again, when I started, my career in transplant, the patients that we saw are so different from the patients we're seeing nowadays, and definitely in much better performance status, which translate to outcomes after transplant. I think one thing that we touched upon before, and I think is really important, is how we actually use the community to learn more. I think that the pediatric and the young adult is a very good example of this. Is at the end, MPN is still a rare disease, and only if with collaboration and gathering data together with multi-center, I think that's the way for us to go. So it's a small community as it is, for the transplant, it's even smaller. So one thing again that we are doing with the support of the MPN is looking into transplant outcomes among many centers that are collaborating. But I think that, it would be wonderful to expand that beyond just the transplant, but actually almost have a registry that every myelofibrosis, any MPN patient is on, and we can over time collect, both samples and clinical information about these patients to just know better and advance the field.
Right. And I know there are a few, but I think collectively, it needs to be one big database that everybody can access for, appropriately. I always tell people at the end of, hearing from both of you to stay with us, because I think it's extremely important to hear from our industry partners. You are hearing from mostly their scientific people that can give you, valuable information about what's happening in their trials with their drugs that will completely impact our MPN community at some point if they haven't already. And so we're starting a little early, so I'm going to just add that aside from our pediatric and young adult program that we try to host once a year, and we have partnered with Dr. Cuisine, we do an annual Women in MPN program, and we don't exclude the men at all. You're all welcome to join us, but we are going to, for the first time in a year and a half, venture out to Washington, D.C., if it's safe to do so. And that's on September 24th. And we have a list of speakers that I think most of you know, and that will be at the Willard Hotel in Washington, D.C., and you'll start to get information about that. We will also in early September host 2 clinical trial update programs with some of our leading experts, like the people you're seeing right here, and with our industry partners. They will be given ample time with slides to explain exactly what's going on. We'll have 2 of those programs, one for patients and one for physicians. And so those are the things coming up in September. So at this point, if Kristen, it looks like she is with us, I would like to introduce one of our partners that's been supporting us forever. And we all greatly appreciate them. From Insight Corporation, Kristen Griffiths is the Senior Manager for the U.S. Public Affairs part of the business. And so Kristen, please let us know what's happening at Insight.
Hi, Anne and team. Thank you so much for the opportunity to speak with you. I'm so pleased to be here to represent Insight. And I'd like to thank the group for having me and giving me a few moments to speak about our company and its commitments to patients. So we work and study these diseases, MPNs, on a daily basis, and truly value these moments where we get to hear from the patients and hear the questions and what's important in affecting the community. Just a little bit of background on Insight. So the Insight Corporation, we are a Wilmington, Delaware-based biopharmaceutical company and really committed to making a difference in patients' lives through scientific discovery. Rigorous science is at the core of everything that we do to develop and discover novel medicines that will meet the serious needs, the medical needs of the patients in oncology and other diseases as well. So something that's important for me to mention is patient access. So one of the most important commitments for us is to help ensure that appropriate patients have access to the medications that they need. And for this reason, we've developed a patient support program called Insight Cares to help appropriate patients and their healthcare providers access their prescribed medication. And for eligible patients, Insight Cares offers prescription drug insurance verification, prior authorization support, free drug and copay assistance for those who qualify under the program's terms and conditions, as well as ongoing education and support from a representative. For more information on how to access Insight Cares, please go to www.insightcares.com. And I highly suggest that all eligible patients enroll, even if they don't think that they'll need access initially, just because circumstances can change. And if an eligible patient is already enrolled, we'll be able to help the individual get what they need more quickly. Just a little bit on clinical trials. We are currently enrolling for clinical trials for MPNs at this time. If you're interested, please contact your healthcare provider, and detailed information about Insight's clinical trials can be found at insightclinicaltrials.com. Once again, that's insightclinicaltrials.com. A little bit on support materials. We host a website called voicesofmpn.com, where you can go and receive lots of information, patient stories, access to information for MPN community events such as Facebook Live, patient meetings, podcast, and a symptom tracker. So I highly encourage you to check that out. We've also created a program called MPN Heroes to publicly recognize individuals who have excelled in the caring for patients and or patients with MPNs who have advanced, or scientists studying MPNs who advanced the science in that area. And we are currently looking for nominations. So that can also be found at Voices of MPN as well. So in closing, thank you so much again. Programs like this allow Insight to utilize its resources to help improve patient lives in the diseases that we work so hard in. So thank you for the opportunity, Anne, and back to you.
Thank you very much. I really appreciate it, Kristen. That was a great overview. And, it's important to note that if you need help, if you are taking Jakafi, that you can contact Insight Cares and they can direct you appropriately. Thanks, Kristen. So now we're going to hear from Lauren Mustove. She is the Director of Corporate Communications at Sierra Oncology. Hi, Lauren.
Hi, Anne. Good morning. Good afternoon, everybody. I'm so excited to be here with you all today. As Anne mentioned, my name is Lauren Musto. I head up the corporate communications function at Sierra Oncology. And if you're not familiar with us yet, Sierra is a late-stage biotech company, and we're really on a quest to deliver targeted therapies that treat rare forms of cancer. Our main focus right now is the development of momelotinib, which is an investigational agent for the treatment of myelofibrosis. Momelotinib is an inhibitor of 3 key signaling pathways that contribute to the major manifestations of this disease. So essentially, by inhibiting ACVR1, ALK2, as well as JAK1 and JAK2, we believe that momelotinib has the potential to improve anemia of myelofibrosis while also improving constitutional symptoms and splenomegaly. So exciting news, we're nearly done with enrollment of our ongoing phase 3 clinical trial, which we refer to as the Momentum study. Now, this trial will compare the activity of momelotinib to another treatment called danazol by assessing the impact that momelotinib has on symptoms, anemia, the need for blood transfusions, splenomegaly, and the safety of the product. The trial is recruiting at more than 160 sites in 22 countries globally, including 15 in the United States. And we expect to have the results from this trial in the first quarter of 2022, so right around the corner next year. And if the study is positive, the regulatory authorities would then have to review and approve the product before it could become commercially available. If you would like more information, we welcome you to visit clinicaltrials.gov and search Momentum for additional information. Again, Anne, thank you so much for inviting us here today. We so appreciate your partnership and all that you do on behalf of patients. And we look forward to working with you all in the future. Thank you so very much.
Thank you very much, Lauren. We really appreciate it and the work that's being done at Sierra. So we'll move on to Dr. Faye Feller, who's the Vice President of Clinical Development with the Geron Corporation. Hi, Faye. And we've been around for a long time. And, you know, I've been meeting with these folks for a long time. So Faye.
Thanks, Anne. And again, thanks so much to the MPN Advocacy Group for hosting these webinars. I always learn something, and I think it's great to bring together patients and experienced clinicians and the industry to collaborate and share ideas. And it's truly great, the work you're doing. Thank you for having me here. I'm honored to be here. So my name is Faye Feller. I'm the head of clinical development at Geron Corporation. We're a late-stage biopharmaceutical company in developing imetelstat. Imetelstat is an inhibitor of telomerase, and we're looking at it primarily for the treatment of hematologic myeloid malignancies. We recently completed a phase 2 study of imetelstat in intermediate 2 and high-risk myelofibrosis patients who were relapsed after or refractory to JAK inhibitor treatment. And this study was known as MYF 2001 or EMBARK. And it showed, interestingly, a potential for survival benefit and an encouraging symptom response rate. So subsequently, we have recently opened a phase 3 study in intermediate and high-risk myelofibrosis patients who are refractory to JAK inhibitor treatment. This study is known as MYF 3001 or IMPACT-MF. It is an open-label, randomized control trial comparing imetelstat to best available therapy. And the primary endpoint for the trial is overall survival, and symptom response rate is a key secondary endpoint. We plan on over 100 sites to be open globally, and you can find additional information on the geron.com website, as well as clinicaltrials.gov, of course. Again, the name of the trial is MYF 3001 or IMPACT-MF. And Geron looks forward to continuing to work together to improve the lives of myelofibrosis patients. Thanks.
Thank you very much, Faye. Thank you for that update. And now we will move on to Brian Murray, who is with AbbVie. He's the Assistant Scientific Director. Brian, hi there. How are you?
Hi, Anne. Good to see you again. Can you hear me?
Yes, I can.
All right, excellent. Hi, everybody. My name is Brian Murray. I'm an Assistant Scientific Director with AbbVie, as Anne had mentioned. In the area of myelofibrosis, AbbVie is investigating navitoclax in combination with ruxolitinib in various studies, which I'll describe briefly. But before we do that, I just want to level set everyone that navitoclax is an investigational agent. It's not currently FDA approved. And it works by inhibiting a protein called BCL-XL. This protein is often hijacked by myelofibrosis cells and cancer cells in general to keep themselves alive, and navitoclax prevents this from happening. So I want to discuss 3 studies today with you. The first is a phase 2 study. It's called REFINE. Sometimes you hear it referred to as M16109. And this is our study evaluating the efficacy and safety of navitoclax both alone and in combination with ruxolitinib. We've enrolled, we've fully enrolled one of the cohorts so far, and we presented data at previous scientific congresses from this study, but we're still looking for patients for other cohorts. And so we have 25 sites open across the US, again, still actively seeking patients, both those who have received a prior JAK2 inhibitor, as well as those who have not received prior treatment. We're looking for intermediate 2 or high-risk patients in this study. So based on encouraging results from this study that have been presented in previous years, we've also initiated and activated 2 separate phase 3 studies. The first of which is called Transform-1. In Transform-1, we're evaluating the same combination that I'd mentioned previously, navitoclax and ruxolitinib, compared to ruxolitinib and placebo in patients who have not previously received a JAK2 inhibitor therapy for their myelofibrosis. Very similar eligibility criteria to our phase 2 study, intermediate to or high risk patients ineligible for transplant. And the second phase 3 study is called Transform 2. So Transform 2, unlike Transform 1, is being conducted in patients who have received a prior JAK2 inhibitor therapy, but have had worsening of their disease or progression, and so require additional treatment. So again, it's the same combination, venetoclax, ruxolitinib, compared to best available therapy. And this is really a physician's choice of fedratinib, ruxolitinib, hydroxyurea. There's other options as well. We started activating sites for these studies just last fall, and we're continuing to activate additional sites. We're looking at well over 100 sites globally for each of these studies. And if you want to find out more information than I provided here, I would highly encourage you to check out myelofibrosisresearch.com. It provides a lot of great information on these studies. There's a very handy questionnaire that you can fill out to determine if you're eligible for one or more of these studies. Additionally, there's a Google map embedded in the website that will tell you the nearest location of the various institutions that have these studies open. So again, myelofibrosisresearch, that's all one word.com. And you can get some more information there if you're interested. So thanks again for your time, and Kathleen, MPN Advocacy Education International. I appreciate, as always, having a forum to discuss our MF program. Thanks so much.
Thank you so much, Brian. Thank you. That was a great update. So now we're going to move to CTI Biopharma. And as you can see, Adam Craig, who's the president and interim chief medical officer, is in the Bay Area. And we have actually had a long-term relationship with CTI Biopharma. They've been great supporters of us, and we followed their drug very carefully. And I think Craig or Adam may have some very good news. Adam, please join us.
Thank you, Anne. Thank you for the introduction. I'd like to thank you for the opportunity also of enabling me to talk about CTI. So for those of you that don't know us, we're developing a drug called pacritinib, which is a JAK2 IRAK1 inhibitor for patients living with MF, particularly those experiencing low blood counts. Our focus on low blood count recognizes the fact that many of these patients have advanced disease and fewer treatment options. We've already studied pacritinib in over 1,200 patients, including 2 phase 3 studies, and we've shown that it's effective at reducing spleen volume reduction. Last week, it was our pleasure to announce that the FDA has accepted our new drug application for the use of pacritinib in the treatment of patients with myelofibrosis and severe thrombocytopenia. It's very exciting news for us, because if we're successful in our application, pacritinib could be available to patients before the end of November of this year. That's great news. In the meantime, we're actively enrolling our phase 3 Pacifica trial, which is looking at pacritinib versus physician's choice. This is enrolling patients in the same population, platelet counts less than 50,000, who have myelofibrosis. And we're including patients who've had prior exposure to JAK inhibitors and those who've had no exposure to JAK inhibitors. So it's open to all patients. Patients are enrolled on this trial 1-to-1, and the choice is pacritinib versus physician's choice, which includes low-dose ruxolitinib, danazol, hydroxyurea, and corticosteroids. So enrollment on this trial is underway, both in the US and worldwide, and details of the trial can be found on clinicaltrials.gov rather. So in the meantime, we're excited. It's a very exciting time for CTI. We're very pleased to have partnership with the MPN Advocacy and Education International, and we will continue to do good work and hopefully bring a new therapy to patients living with MF before the end of the year.
I'm so excited to hear this news. That's fantastic. Thank you so much, Adam. We're very, very pleased.
Thank you, Anne.
So we will hear from Sean Yee, who is the field medical director from Constellation. Hi, Sean Yee.
Hello, Anne, and thank you again. It's always a pleasure to be part of the conversation. So hi again, everyone. I'm Sean Yee Liao, field medical director at Constellation Pharmaceutical Medical Affairs. A little bit about Constellation. We are a Massachusetts-based biotech company with over 12 years of discovery and development history focused on epigenetics and cancer biology. Our drug candidates, which were all internally discovered, are the products of our expertise in gene targeting and in diseases where gene regulation and control matters. Our lead compound is an investigational BET or BET inhibitor, pelabresib, also goes by the name of CPI-0610, that we are developing as a potential treatment for myelofibrosis. Constellation is currently conducting a phase 2 clinical trial of CPI-0610 in myelofibrosis, and a larger phase 3 study called MANIFEST-2 has initiated. For more information, you can find both MANIFEST and MANIFEST-2 study at clinicaltrial.gov or check out our website at constellationpharma.com. We all recognize that we need new therapies for MF patients that address the areas of unmet need, and we're working hard to develop such a therapy. At Constellation, our clinical and research team are deeply invested in scientific approach to bringing therapies to patients. Our interest and commitment to patients and caregivers extends across the MPN community, as we have additional plans for pelabresib and early stage programs that may have utility in MF and other MPNs in the future. I applaud this community of patients and caregivers suffering from the consequences of MPNs. It truly inspires us to work every day to develop these new therapies. And a final thank you to you, Anne, and your group, MPN Advocacy and Education International. Again, it's always a pleasure. Back to you, Anne.
Thank you very, very much. Thank you. We love our work. Don't we, ladies?
Yes.
Say yes.
Yeah.
And so finally, we're going to hear from Dr. Ray Urbanski from Pharmacentia, and I think Ray has some good news as well. Are you with us, Ray? There you are. Hi.
Hi, Ann. How are you?
Good. Thank you.
Yeah, so just to give an update, I heard ROPEG interferon mentioned during the conversation as well as Pharmacentia, so I'll update everyone. We submitted the additional requested information to the FDA on May 13th. So our current action date now is November 13th. So we're hoping that the approval will happen either on that date or prior to that. So that's an update on our polycythemia vera trial. Also of note is we are starting our named patient program simply because of the delay in the original approval date. We've received several requests to get ROPEG interferon available to some patients who may not qualify for clinical trials, and there's no other alternative. So this information will be on our website under our named patient program. We'll have the forms that need to be completed, et cetera, and investigators can certainly go there to take a look. And then last but not least, a little update on our global essential thrombocythemia trial called SURPASS-ET. 60 sites, Asia Pacific region, about 10 in Europe, 10 in the US, and 4 or 5 in Canada. We're looking at last subject first visit, so basically the recruitment to be completed end of Q4 of this year or early Q1 of next year.
Fantastic. That's really good news. So patients and caregivers out there and physicians out there that see MPN patients, we've got some good news in the pipeline and for our patient population. That's fantastic. Thank you, Ray.
Thank you,
And
Ann.
so once again, I would like to thank Raajit and Roni for joining us today. Thanks for sitting through all of this and answering all those questions. And we will be taking a bit of a break. We're still here. We'll still be here for our patients. If they have questions or want to call us or email us, we're still here. But this program will be our last one until September. And we'll take a little bit of a summer break, and we wish you all good health. We'll be putting some more healthy recipes up on our Go With The Flow website, and we'll direct you to that in our update that we send from here. But thank you all again. It's been fabulous, and I miss you all, seeing you in person, and hope that some of you will join us in Washington, D.C. Thank you.
Thank you, Ann.
Thank you. Bye.
Bye.
Bye.